We're going to go over the model multidimensional family therapy. It's a treatment that works with families around adolescents' drug use and also their engagement in delinquent behaviors. And so, what we're going to cover in this presentation is the model development, the research that's supporting it, and how it's been disseminated throughout the United States and sometimes the world. In this, we're also going to cover its theoretical foundations, the practice that clinicians implement, how it also engages in supervision and training of its clinicians. So we'll start with the model development. Essentially, multidimensional family therapy, it's an evidence-based practice that has some rigorous standards and extensive research of support. And what it does is it targets adolescent substance use and other acting out behaviors such as delinquency. And so then essentially over 2 decades of research has been conducted on this model. And this model has been shown to be effective through 4 different types of studies. There's outcome studies, which shows what are the end products that we see as a result of going through this. Process studies, which look at the implementation of MDFT in different settings. If it's cost effective, in other words, it decreases the cost that we have put into residential treatment programs, or the number of times kids have gone through different programs, and how it gets transported or disseminated into the community, and to make sure that people are maintaining fidelity to the ideas of the model. And so in those studies, what we found is essentially there's been reductions in substance use among adolescents from 41 to 66% reduction. So basically, when kids come in, we see them at a certain level, and when they leave, their substance use has decreased between 41 to 66%. We've also seen some improvement in psychological functionings, particularly around internalizing or taking what's going on and making it, bringing it inward, and externalizing, basically acting out what's going on within yourself. We also seen improvement in school and job functionings. Parents have been doing better, and they're demonstrating some improvement, and the interactions have been improved within the family. But we also see that kids are involved in fewer and fewer arrests as a result of going through this program. And so overall, what we see is a decreased involvement in drug use and actually engaging with peers who are involved in problematic behaviors themselves. And so in one study, what we found is that essentially of 182 adolescents who are using drugs or alcohol, randomly assigned to one of 2 groups, one of them being MDFT, another being a treatment group, or another family intervention, there was a 42% decrease in drug use among kids who are in the MDFT program. Whereas essentially MDFT was the only intervention that showed an increase in family functioning. And with that, we saw improvements in academics and essentially the GPAs. So unlike other programs like an adolescent treatment group where you're just taking adolescents themselves, or you have multiple families and you're putting them through education only, MDFT actually does better than other types of interventions. And the treatment gains were maintained 12 months after follow-up. So in other words, a person leaves the program, 12 months after that, we follow up with them again, and we still see the gains being maintained over time. So MDFT is not only effective in reducing problematic behaviors initially, but also long-term. And so if you think about when kids come in, if we can engage with them, how long are they going to stay in the program? This is something that everyone is actually addressing. So if we bring these kids in, how are they going to stay? How long are they going to stay? With MFT, we have a 95% retention after 90 days. Whereas comparing MFT with some of the others, after 180 days, we still have a 95% completion rate. So what ends up happening is kids come into the program and they end up staying and they end up doing better as we go along. And this is whether you compare residential programs or group programs to MDFT. What we also see is that essentially there is levels of cannabis use, and in something like cognitive behavioral therapy or CBT, we see that there's a reduction in cannabis use 6 months after. However, with MDFT, we see a greater reduction, essentially between the baseline and post-baseline measures. So if we take a kid into a program and we put them through this program, we can see that kids are doing better in reduction of cannabis use. So essentially what we find is that there's reductions in overall drug use that are greater than CBT alone. Now, if we look at psychological involvement with substances following up, so basically kids that are essentially going through, they're essentially, how are they functioning psychologically? What we find is that they're doing better. Now, essentially, one of the things that might be a goal for some parents and some kids is abstaining from drug use. So not only stopping it, but completely abstaining for it. What we see is at intake, essentially between MDFT and CBT, MDFT does better at intake and discharge 6 months after and actually 12 months after. That essentially MDFT gets kids to stop using substances at a greater level overall than CBT. Now let's look at how the model is implemented in the program. So first of all, it was developed in Miami, and it was actually developed for something different than what it is right now. But basically, they developed it in Miami to work with adolescents, and by virtue of the need to meet with clients, it went in-home. And that was successfully translated. The program that you see now is successfully transported to different states, including Connecticut. Now, Connecticut has statewide implementation of MDFT, so all the regions or the areas of Connecticut are covered by an MDFT program. And it's actually moved into international settings throughout Europe, in that they're using MDFT in many, many different settings. So Connecticut MDFT is actually a DCF initiative to bring evidence-based practices to Connecticut. And what we're trying to do is reduce the number of kids who are going into out-of-home placements. And we're actually trying to essentially save money over time by helping families stabilize and be able to manage whatever's going on in the family, so that they don't have to go in for services unless it's essentially necessary and there's some outside thing that a family can't handle. And so we have, in 2008, there was 8 providers. I have to look and see what the numbers are today, but actually it's much higher. We have, in 2012, 14 providers, many different teams and therapists. And these are people who have been trained in MDFT and maybe are remained in MDFT, but also providers who have come in to MDFT and then moved on, but they still have that MDFT knowledge, what they can use with a variety of clients. And so then what happens is there's these consultants, these MDFT experts that consult with providers and help new providers and ones who have been doing this for a while implement effective MDFT services in their practice. And what they do is they bring it back to the theoretical foundation. This is what the information that supports MDFT. And so what we have is essentially MDFT is developed based on certain ideas. And one of these ideas is adolescent development. So we have to understand how adolescents develop over time. And so this harkens back to some of the theories of human behavior in the social environment, where we're talking about Erikson's psychosocial stages of development, but we focus on the adolescent time frame. But we're also biological development, psychological development, cognitive development, social and spiritual development. We also look at parenting practices, so what parents are doing to manage the behavior of the kid, but also the family functioning. Are they working together as a unit? And we look at risk and protective factors for kids' problems. And we take this, we put it within the ecological perspective and within Minutian structural perspective and problem solving. And the way that we bring these all together is by understanding it. Adolescent substance use is many multifaceted. There is not one particular reason that adolescents get involved in substances, but there are many facets or reasons. And what we look at is the risk factors and how they reinforce each other, and what diminishes or protective factors stop or inhibit the engagement in problematic behaviors such as crime, delinquency, drug use. We also define things in context. So unlike other therapies, what we do is we go into the context, we look at the context and say, how is this influencing the kid's behavior and the problems we're experiencing? And we understand that substance use is a systemic problem, and it derails development. So using substances affects how people develop socially, spiritually, psychologically, emotionally, and family-wise. And so then we treat the family as the context for healthy development. That if we work with the family, we will work with the kid. If we work with the family problems and the family functioning, it will affect the kid and their functioning. And so then we also consider peers and influences, peer influences on the family and also the kid's functioning. So we're going to start off with risk and protective factors and talking about how that looks. And so risk and protective factors can be on the individual level. They can also be on the peer level. They can also be on the school level. They can also be on the family level and the community level. And what we're doing is saying that risk and protective factors are not in one place, but in multiple places, and that they help. Risk inhibits, protective factors facilitate. And so what ends up happening is the community environment can be one in which it creates risk. So poor environments where there's a lot of drug use and social upheaval would be an example of a risk environment. Living in impoverished neighborhoods, high rates of transition and mobility, so families moving in and out of the neighborhood to chase lower rents would be an example. But also groups that are culturally disenfranchised, that they're essentially, because of who they are rejected from parts of society or have trouble engaging with parts of society. And so then what we have is protective factors which actually facilitate healthy development. In the community, that might be a caring and supportive community. So growing up in a community where people are watching out for you and are essentially looking out to see that you don't get in trouble would be an example. But high expectations for youth around media literacy, understanding that, if something is on TikTok and it says to try something out that is dangerous or risky, the person will say, you know what, that's maybe not such a good idea because this is TikTok, and they might not be truthful in what the risks are. But also counter messages. So think of the adolescent smoking campaigns and the adolescent counter smoking campaigns, how it's not cool that you'll lose, if you've ever seen the losing of the teeth. But also religious-based activities for those who engage in religious activities. So where there's a pro-social group that's not involved in what's going on in the community, that can act as a form of protection. But also community-sponsored activities. Many years ago in the 70s, there was midnight basketball was shown to be very effective in decreasing youth involvement in gangs. So then, essentially, the community environment facilitates risk and protective factors in other ways. So the community environment can influence parent criminality and abuse of drugs. So if it's available, parents might get involved in drugs, which means the kids will get involved in drugs, more likely than not. But there might be also a lot of conflict and abuse within the family that goes undiscussed within the family because a lot of people are engaging it and no one's essentially intervening with the family. But there might be low parental support, and this can be in a lot of different ways. Parents might be completely emotionally and physically and psychologically absent from a kid's life. So they're not monitoring them, they're not seeing who the friends are, they're not checking up to see if the adolescent is going to school. And so they're not necessarily managing the family in an effective manner that moves a kid away from drug use or delinquency, but towards essentially doing whatever it is that their peers are doing. And so then essentially, if a parent thinks it's okay for a teen to use drugs and alcohol or skip school, they're not going to do anything. And this could be the parent does not want the child to be in drugs, but they don't say anything when the kid uses drugs or when they skip school. The last thing is much harder thing is a parental mental illness, and this could be diagnosed or undiagnosed. So if the parents aren't mentally healthy, it's hard for them to engage effectively with their child. So at the community environment, these risk factors can essentially influence the family and the family's sense of protection. So essentially, if you have a supportive community that essentially engages in collective supervision of the kids, there might be more emotional support for the parents as we're going through something like the quarantine and how stressful it is for parents. There's a basic sense of trust. So I trust that when my kid goes outside, they're going to be watched by other parents. I have high expectations for my kids. They might be going to school every day, and I expect them to do well in school and engage in school. And I have rules and expectations from that I impart to my children. When they break a rule, I enforce an expectation or an outcome or a punishment. But I also am clear with them what I expect and what I don't expect. I monitor what's going on with them, and I facilitate a positive bond. It's not all about essentially making sure that the kid is doing everything right and punishing them constantly, but understanding my community environment, creating a family environment where we have a bond, even if everything is going crazy in the outside world. There's a lot of drugs, there's a lot of crime. I bond with my kids so I can protect them from that environment and show them a different way. And essentially what you have is the community environment influencing the family, which then goes to the peers. And this peers and partners goes back and influences the family and the community environment. So this is where the ecological systems perspective talks about interaction, so that one thing affects the other and the other affects something else. So everything is influencing one another. And this goes for risk and protective factors. So basically, if you have peers who are involved in problematic behaviors or think it's good to be high and drunk, they're going to influence the family environment and the community. And it might be through the identified child. But if you have kids who are, stealing, doing, are not monitored, it increases the likelihood that will happen with the child that you're working with. Because they can say, for example, I'm going over to my friend's house knowing that their parents are not going to monitor them or even give them drugs and alcohol. And, there might be fear of being rejected by peers, so you engage in other things. And kids with, or peers with poor social skills are going to impart that in one another. And in terms of protection, we can see involvement with peer group activities that are pro-social is a protection. So if I'm on a sports team and the sports team is one in which kids come together, there isn't this essentially drug use, would be a good thing. But remember, that sports team could be another gateway to other problematic behaviors. So we don't look at something and say, this is sports, it's good, this is peers hanging out, it's bad. It's what are they doing? What are their group-based activities? And their competencies. So, if peers can make some good decisions, let's not go down that way, because that's where a lot of people are shooting up or drinking, then, that's good. But also, that peers are communicating with each other in a more effective manner, in a manner that essentially suggests that they are thinking through the risks in their environment and kind of negotiating with that so that they can avoid it. That's essentially how the peer partners essentially influence the family and the community. So with the MDFT theory of change, they have a very clear, and it seems complex, but it's actually not, theory of change. So the first is MDFT interventions identify what's going on between people and between levels. So between the family and the community, but also between people and the family. So let's say the parents and the child, but also what's going on for each process. So what's going on in the community. If you think about right now, we're going in the community and dealing with a pandemic and vaccinations and people's beliefs and all of the racial injustice that's been happening, the widespread shootings. How is that affecting the community, but also how is it affecting each person within the family? So you may have in some families people who are afraid for their children going out into community because of the gun violence, the pandemic, and the targeting of African American and Asian American people. But you also look at risk and protective factors and how they influence one another. And essentially what you're trying to prevent is that risk factors outweigh protective factors. You actually want to have more protective factors than risk factors. You can't eliminate risk, but you can lessen its effect by increasing protective factors. So if you think about a community, you may not be able to eliminate drugs in that community, but you can essentially buffer the exposure to drug use by having activities that a person can engage in that pulls them away from drug using people in the community and friendship networks. And basically, you look at the intervention target, what you're trying to change, as a pathway. So by providing access to pro-social activities, that is a pathway for them to change. It doesn't mean they're exactly going to change, but it's the mechanism that you're going to use to change. And so then essentially, ending problematic behavior becomes meaningful if there's concrete opportunities to engage in something else. So what essentially that means is that if I have pro-social activities, if I can learn to go someplace and do music mixing, that can be an alternative to hanging out with my friends on a corner smoking weed. And essentially, if you affect one thing, multiple things will affect. So if I have a kid move into learning how to mix music in a music studio, that will affect their ability to hang out with friends, but also smoke weed. And it may involve me needing to go to school. So that essentially one thing is affecting multiple risk factors. And so then it becomes a situation where one target, identification, one intervention target ends up affecting multiple aspects of the risk factors in a person's ecological environment. And so you're not necessarily trying to find that one magic pill, but you're thinking, if I do this, how will it affect other parts of the individual, the family, the peers, and the community? So in the theory of change, essentially one of the things that you're looking at is helping the adolescents and parents build a relationship that is supportive. And there's a couple different ways that we'll talk about this, but essentially one of the things you're trying to do is target whatever's going on within each person, so within the adolescent, within the parents, but then their interaction with each other. That goes back to the idea of the interpersonal and intrapersonal aspects. And you're essentially going through symptom reduction, and you're trying to increase pro-social and development, pro-social behaviors and development. And what you're doing by doing this is essentially you're targeting the family. So what's going on in the family? But remember, when you target the family, you're also looking at what's going on within each individual. So if someone has an undiagnosed mental illness, you're going to start to treat that. But if you're also looking at the interactions between family members. So you may engage in some work to essentially help families recognize each other's strengths. But you're also facilitating connections across all the ecological domains. So, helping a teen get involved in a pro-social group, maybe doing some connections with parents who are experiencing similar things to get parents to understand that they're not the only ones. Working with the family together to make a meal. but also going outside the family and thinking about schools and the community and how this family can get connected to other resources. So MFT targets certain domains for change, and there's essentially a collection of 6 of them. And so the first one is drug use. Obviously, we want to target adolescents and sometimes parents' drug use to decrease that. But then we're going to look at adolescents' identity and development. And I'm going to come back to this in a second because it talks about other parts. So part of what influences people's adolescents' identity is their peers and how they influence them to engage in certain things. The idea behind this is that peers end up becoming a source of information about a person's identity. But also, we want to increase people's connections to pro-social institutions. So institutions that are going to move adolescents away from drug use and delinquent behavior or acting out towards acting in a way that helps adolescents become connected to people who are not involved in drugs and delinquency. But also we're going to address racial and cultural issues and health and sexuality. So now, adolescent identity is influenced by peers, as I said, but also racial and cultural issues, health and sexuality. And so what we're talking about here is the normal progression that adolescents go through as they're developing their identity. So experimentation is a part of identity development. But what we're looking for is to create opportunities for pro-social identity development. Healthy sexuality, healthy gender identity, health behaviors that are in line with facilitating people's development. So things like if an adolescent has diabetes, that they're taking their medications in their regimen as indicated versus not doing so because of drug use. So what we end up doing is targeting these 6 areas, but as you can see, some of these interact with one another. Again, think of the targeted domains as part of the ecological system and the interaction. So as you target one thing, you're targeting others. In terms of the clinical process has particular ways of doing things, but it's not lockstep. This is essentially a framework that you operate within in your practice. And so then there are 4 intervention targets in MDFT. And the first one is expected. The first and second one is expected. It's the adolescent and the parent. Because we're talking about family therapy, we have to have family members. But we also look at the family interaction, so how adolescents and parents are interacting, but also the relationships that they have. Because what we're trying to do is facilitate attachments between parents and adolescents. But we also look at systems outside the family that might impact the family. So this could be juvenile probation, this could be the school setting, this could be medical providers, peers. Essentially, we're looking from the ecological perspective. So we look at the family and people within it, but we go outside that family and engage in multiple stakeholders in this intervention process. And so the way we do that, the logic is we look at essentially the adolescent, and this goes back to the idea that we are looking at multiple groups. We look at the parents, we look at the family, and we look at the extrafamiliar stuff. And so then as we do that, we consider that problems are multidimensional. So if a child has untreated mental health, that's related to the adolescent, but it also might be related to the parents. They might not identify what the child is going through as a mental health problem. It might be related to the family in that they're uncomfortable addressing mental health or don't know what it is. And it might be related to systems outside the family in that they have trouble getting into services that are needed. And so we look at all problems as having multiple dimensions. And multiple dimensional problems require conceptualization of how all these facets or components interact to create and sustain the problem. So they're sustaining the risk factors and they're sustaining the protective factors. And so then what we end up trying to do is have interventions that go across systems so that we can address the multiple problems and the influences that are sustaining that problem. And so then we assess and intervene on the multiple systems. Okay, this sounds complicated, but is actually very simple. And so as we go through the rest of the clinical process, you'll see how that works. So basically, we start to think and act multisystemically. So we look at the therapeutic system. Typically, we're taught to think about the individual, so the adolescent or the parent. But what we're going to do is we're going to assess the multiple systems from the beginning. So we look at the adolescent, we look at the family, we look at the relationships through this. We can use some tools that will help us do this, genograms being one, ecomaps being another. And so we do this so that we can get some different ways of understanding how the family views their social world, but also the different patterns or pathways that we can lead to change. So different things that we can do to influence change. So then we conduct multiple types of sessions. So we may meet with families several times a week. We'll meet with the family, we'll meet with the parent, or we'll meet with the adolescent. But we're covering all groups. And we engage in shuttle diplomacy. So we talk to one part, and then we talk to the other part, and we become the connection in that negotiation to get them to start talking. And so then what we do is we connect ourselves to the school and court personnel. So as a clinician, one thing I might do is attend a PPT so that I can make sure that, one, the parent understands what's going on, but also if there's things that I need to address that the parent might not be sure how to do it, I can help the parent do that. And here's where I'm essentially addressing maybe a learning difference that's informed by a mental health, and I'm doing it multisystemically. I'm helping the school understand the child, I'm helping the parent work with the school, and I'm helping the kid by getting services that he needs. And so then we have to think about what is therapeutic. Basically, you're showing people what's in it for them. That if they start to get services, things get better, things change. And so this will motivate people to continue to participate in treatment. And as they continue to participate in treatment, the idea is they start to see how things improve. So we have to think differently about how we assess and engage. We're assessing multiple things, but we're also assessing people's motivation. And we do that by considering what is in it for them. And so then when we look at parenting interventions, so then essentially if parents are functioning, they're going to engage in practices that are going to help kids move away from drug use and delinquency and towards more parenting outcomes. So what we do is we engage parents in changes in their parenting practice, understanding that kids will change because we are working with them as well. And we're doing this even understanding that a kid is currently using drugs. So if they're currently using substances, we are still working with the parents to change how they're engaging with the adolescent, with the understanding that things will change. So you're changing the system. But we also have to develop a strong alliance. And this is essentially, we're connecting with the parent. We're not seeing them as the problem, but they are part of the solution. And so as we do that, we can get parents to participate in change because they're not essentially feeling like they're doing it alone. And then what we try and do is we think from the perspective of the parent about their distress about the circumstances, what's going on for them, and what they think could be different. And sometimes we might have to coach parents in understanding what is possible, because they might be steeped in fatigue, despair and fatigue, because they've been dealing with this for a long time and have run out of options. So we essentially carry the hope for the parents at times. So in terms of the family domain, one of the basic things we do is an enactment. This is where you set the stage to see the family dynamics enacted in front of you. And so then what we're doing is essentially this helps us help the family experience each other differently. So if we think about what we might say to what a clinician might say is, well, you need to communicate better. Well, what is getting in the way of the communication? How is the communication being fostered? What is the underlying message that if someone is trying to communicate in a way that you think needs to change? So if a parent says, you know what, I can't deal with you anymore, that is the message, but under that, the parent might feel like hopeless, that they have run out of options. And so what we're trying to do is look from the family's perspective about how they're interacting and see what might be the underlying message and bring that to the surface. So what we're saying is that the parent doesn't want to give up on the child, but what they've done is they feel like they've run out of options and they don't know what else to do. And so that's where we bring in the hope to get them to participate in some change efforts. And so we create the experience of new realities. We basically, we do things in a session, like getting the parent to explain, I feel like I've run out of options, but I don't want you to be hurt. And then we have them outside of the sessions practice that. And when they practice it, we come back to it and see, and this is the problem solving part, what got in the way. And then we give some tips and tools and they practice it again. And we constantly are doing things in the session and having the family do stuff out the session to practice what we've done. And so then we look outside the system. And so we are thinking about what kind of needs they may have. This is the basic hierarchy of needs: food, clothing, and shelter, love and respect. And so then we also are going to consider psychiatric and medical referrals. There may be the parent or the child that has undiagnosed mental illness. So we may have to refer them outside for psychiatric assessment to get medication if the kid is chronically dysregulated or a parent has an untreated bipolar disorder. But we're also going to look at legal things. So if a kid is involved in acting out, they may get involved in the juvenile court system or family court. So we have to figure out what's going on for them, what their requirements are, and if those requirements end up conflicting with other requirements, for example, things that are going on in school. So we're looking at the legal, but then we go into the school and figure out what's going on here. Child might have undiagnosed learning needs. They might have conflict with parents. They might be triggered by something a teacher is doing. And so we're assessing that to bring that into our intervention by addressing what's going on outside the family and how it might be affecting in the family. But we're also going to essentially look at immigration status and immigration stressors. So we will sometimes work with people who are undocumented, and we have to figure out how that immigration process has influenced the family and what we're seeing going on. And part of what we end up doing is connecting family and kids to pro-social activities. And so this can be a variety of things. Pro-social activities could be tutoring or interventions for learning disabilities. It could be sports programs. It could be arts programs. It could be maybe friends who are involved in something else. We are creative in the pro-social activities that we engage people in. This could also be like social groups. So if a kid has come out as gay, lesbian, bisexual, or transgender, then we might connect them with other people who are support groups or teen organizations. So they're around other people who essentially are help fulfilling that identity development process, but engaged in pro-social activities. And so now when we think about the stages of treatment, these are really broad stages, but they actually help us structure the time we're spending with families. And so the first one is we are building the foundation. We have to do this so that we can get families to participate in treatment. So at the point that we receive the referral, we're developing an alliance, we're assessing and increasing motivation. And by doing this, we're figuring out, okay, what do you think can change? And if they're saying nothing, we are the hope that we're bringing in. And we're talking about what might be things that are changed. And we might start off to build motivation just with small things that can be accomplished to reinforce that change is possible. Then we do what's called working the themes and requesting change. We look at what's going on in the family and we start bringing in small things to make some changes. And that's the request for change. Then what we do is we essentially seal the changes. We have families think about where they have gone and all the things have changed. So when we leave, they can generalize what we've done in treatment outside of the MDFT process, so that they can continue having the growth that they have demonstrated, and essentially will only need to access services when it's beyond the skill level or the knowledge level of the family. But it won't be in terms of crisis, it'll be in terms of seeking out help. So now what we're going to do is go through in more detail each of the stages. So the first one is basically 1 to 2 months after you meet with people. This is a short-term intervention, so we are doing some things in time frames. And so then essentially what we're doing is we're building rapport. And we're engaging all of the people who are part of the family, however that's defined, to be part of the therapeutic process. We want them to essentially help out the adolescent and the family and participate. So everyone who's considered family, we're working to get them involved. And we have to think about what's in it for them. And so with the adolescent, we're basically helping adolescents, and we're doing a process where they're formulating goals in conjunction with us. And so the goals will look different. Goal writing will look different in MDFT than other places. So other places we talk about SMART goals where it's measurable, it's achievable. What we're doing with collaborative goal formation with adolescents is we're putting it in their words, so that they can relate to the goals that that are set out for them. But at the same time, we understand that by having them do the goals, it's increasing motivation because there's something in it for them. As we're doing this, we're also assessing for other things. We're looking at mental health. We're looking at substance abuse. We're looking at identity development. We're looking at depressive symptoms. We're looking at suicidal ideations. Or suicidal attempts. We have to look at all of that because, of course, this is within the adolescent and it might be something that's influencing the problems that they're getting into. But then we do something similar with the parents. And so we look at what's going on for them right now and what's going on in the past, what they're doing right now to parent the child and what they've done in the past. And what we're doing is essentially getting parents to understand that something can be done, but that they're the medicine, that if we work with them, we can help the family change. And that despite they might feel like this is not doable, that something is doable. And so then we essentially move past the mistakes. We acknowledge, yes, they might feel like they've done something wrong in the past, but we can do something now. And so we're forward thinking and we're moving them towards getting involved in change. And so then once we've looked at the adolescent and once we've looked at the parent, we look at the family. And in the family, we're looking at how the adolescent parents interact, how all family members who are identified interact. And we're looking at the family development, so how the family was formed, and everything from like, why did the name of the child, why did the parent pick the name of the child that they picked? And so then we're also looking at how the family responded to crisis. And if you think back to the family cycle, this will give us an understanding because we have the crisis and then we have the interactions. And if there has been a relationship with a psychiatrist, what that was like, because an adolescent might be untreated for a mental health problem because of how this the family is interacting with the psychiatrist and they might not feel like they're getting their needs met. So after we've done that, we move into the working of the themes. And the working of the themes is we might essentially look at the theme related to communication. And so the adolescent might explain that the parent is restrictive, that essentially that the theme of when a crisis happens, the parent of the kid cuts. And what we're going to do by requesting change is develop new ways of talking with each other. And this is where the shuttle diplomacy might come in, but it might also be that we get parents adolescents to try and say something a little different. So we do some coaching around how to talk about what's going on. But then we look at the parent. So we're still, throughout this, instilling hope for change. But we start to build, if there's multiple parents, we build a united front. So it's not that one parent is saying one thing and another parent is saying another, because that's a risk factor for engaging in drug use and delinquent behavior. But we're essentially addressing the parent conflict so they can be a united front, and coaching the family about the parents about how to interact with the child, that moves them away from you're doing something bad to what the feeling might be. That a child, essentially, if there's a move and their life has been disrupted because they're trying to find less experienced rent, that the child might feel isolated. And we are going to shore up the discipline between the caregivers. So what we're essentially doing is making sure that both caregivers are consistent in the discipline, and then whoever, regardless of who identifies the discipline, that they're both handling out. And so then we basically are looking at how the adolescent interacts with the parents in differences in their response to discipline. And so then as we're doing this, what we're doing is teaching the parent to understand the child. So we have to teach the parent about what is normal and expected in adolescence, regardless of what's going on, and what is essentially related to delinquency and drug use. Because parents might conflate those two things and assume that everything that's going on with the child is related to drug use, whereas essentially moving away from the parents and developing a sense of identity is a normal developmental process. And so then we can increase parental involvement with the child. But then we go back to the family, and we make sure that now, since we have the caregivers working together, we make sure that the adolescent and the parents are working together to address things. And so we essentially we encourage families to address what's called age-appropriate negotiation. So age-appropriate negotiation is essentially, there's certain times where an adolescent can make requests and say, well, can I do this instead? And there's, like, if a child is 16 and they want to stay out a little bit later to go to an event, that might be appropriate, whereas if they're 12 and they want to stay out till 2 o'clock in the morning, that might not be appropriate. And so what we're doing is looking at adolescent development, and we're saying what is appropriate for to be negotiated at this time. And so we continue to focus, move from the behavior to the emotions that are essentially driving the behaviors that we see. So loneliness, apathy, sadness. And then we start to get the parents and the kids to talk about what happened in the past, but in a way that builds on that communication. So we get parents to talk about how they felt in the past when things started to change, but we get the adolescent talked about when they felt like things went downhill. And this if you go back to the family cycle, it'll help you think through this process. But then we essentially we go outside the family and start to look at, okay, can we get you into pro-social activities that leverage or pull you away from drug use, delinquency, acting out, internalizing? And so what we're doing is getting the family involved in stuff in their community or in their school, so that essentially they have something else to deal with and they're not necessarily isolated. Again, the idea is to increase the protective factors while decreasing the risk factors. So then at this process, as we're in the third stage, what we're doing is we're looking at the progress and saying, wow, look at how far that you've gotten. And we're essentially reviewing the parenting styles and the safety plans that people have implemented and how these changes have occurred. And we're getting the people to think back and say, what is different? What did they see as different in the family? What does they see as different within themselves? What they see as different within the adolescent? Getting the adolescent to say what's different in the parent, what's different in the family, and essentially figuring out how they can maintain these changes over time. And so then we essentially look at the process and the content. So when we talk about more positive communication, what does that mean? How does that look between the parent and the adolescent? What might have been communicated more recently that hasn't been before? And so then we may refer people to an outpatient provider to address maybe mental health, to seal or extend some of the ongoing support and work that has been done within MDFT. And so the idea is that essentially as we transfer the person to the new clinician, we get the parents and the family and the kid to think about all the changes they have and be able to communicate that to the new clinician so that they can continue the work. And then we essentially secure pro-social activities. We make sure that the activities that we've gotten them the kids into while in MDFT is something they can continue after they have concluded. But then we get the parents, because we built relationships between the parents and say the school or the community and the church, we get them to continue to work on that on their own. So then we can essentially move out of the treatment phase and the family is able to be supported, and they're in essentially a lower level of care from this intensive intervention to an outpatient intervention, and they're doing better. This prevents out-of-home placements and further disruptions. And so then some of the interventions that are key is you have to have multiple therapeutic alliance. Essentially, you are juggling many different alliances at once: the youth, the family, and outside resources. And so this is for people who are willing to essentially be connected to a whole bunch of people. Therapists have to be able to be flexible in connecting with multiple groups. But we have to be able to enhance motivation to change. We have to stay positive, and no matter what's going on, figure out what has improved and constantly reinforce that there have been even small changes that people might overlook. We essentially we keep reinforcing that, and we talk about how important it is for the adolescent and the family to change so that bad things don't happen in the future. But then you essentially have to be respectful to everyone. So you have to be able to put aside personal judgments you're making about family members and work with everyone in a way that encourages them to participate. So then we have multiple change targets. So we're addressing multiple dimensions, and we're constantly building on strengths. So we're not necessarily looking as much at psychopathology, even though we are addressing that, but we're saying what are the protective factors and how can we build on that. And so then we're constantly celebrating the small successes. Even if this is something like we got everybody in the same room, that's a success. People didn't yell for 5 minutes. That is a success. What we're also doing is we're facilitating meaningful discussions. And by meaningful, what we're talking about here is the emotional part, not the behavioral, not the name calling, not the judgment. But we're getting people to talk about the emotions that they're experiencing and get people to then communicate with each other, getting the youth and parents to talk about that. And helping each group understand the others. So we might have each caregiver and the youth, and we're essentially getting all of those members to understand what's going on for the other person. And we're doing this to resolve conflicts. We're taking past hurts and we're trying to get some resolution, even if that's the understanding that it hurt everyone at the same time. But we're also doing problem solving. So we're looking at parenting practices, maybe house rules, doing conflict resolution, making sure that people are going to school every day, engaged in courts. And we're doing this to essentially address crises, but we look at crises as not a bad thing. We don't look at mistakes as a bad thing. It's an opportunity to figure out what went wrong and what can we do differently. So we're constantly moving ahead, even if people feel like, well, I tried this, but I made a mistake and it didn't work. I thought I could go out with my friends and I wouldn't smoke weed, but I did. And the parents are upset. Okay, so let's figure out what happened. So that's where we're looking at the failure or the crisis as an opportunity to look at. And maybe it's the kid thought, well, I'm doing well, so it could be okay to be with friends. And they realize those friends are actually going to pull them into problems. So that's where the failure or crisis becomes intervention opportunities. So then we're doing alliance building, okay? And we're building alliances between all the people. And outside the family, we might look at people who are influential. This could be a teacher, a coach, a mentor, a neighbor, a family member. So then we complement, we agree, we empower. We're saying, yeah, that's a really good idea. And we're listening. Have you thought about the fact that your son or daughter is saying that they feel alone? Mom, dad, have you ever thought about a time where you felt alone and how that might be? So we're building the alliance between the youth and the parents. And we're getting them to work together. So, if we're doing a genogram, we're getting them all to develop the genogram together to essentially figure out what has gone on in the family and how they can make it better for everyone. And so then for motivation, essentially, there's a couple things that we need to think about. One is despair. The idea of being having despair, it does impact motivation. But you can have despair and hope that things change. And this can be simple as you come here. So even though you feel like things are not going to change, you're coming every time we meet, so that there is some hope there. Okay? And my job as a therapist is to work and eliminate some of the barriers or reduce them. So sometimes as a therapist, going in an MDFT scenario, I have to have the energy and focus that the family might not have because they have low morale. And so then I come and I might bring concrete alternatives. I might throw out ideas that the family can either latch onto and try. And that's creating a new context. I'm essentially creating a different situation or a different way of seeing it that's going to bring new experiences. And so I also bring in resources that from outside the family that might help the family change. And by doing all of this, I'm enhancing motivation. So then essentially, you're focusing on the present. That essentially MDFT is trying to stop a child from ending up continuing to use drugs, out of home placement, removal from the family. And we are using the distress to help people move. We don't want this to happen. So we are essentially using the pressure in a positive way. And you're reinforcing to the family that we are going to solve the crises as best we can, and we're going to do this together. And so we focus on relationships. We essentially problem solve. We get to figure out what people are unhappy with. We do collaborative goal formulation. When problems happen, we try and solve them. And we essentially don't necessarily come in and say we're going to do everything the same. We talk constantly about how things can change. And this means we might have to change our treatment plan. It is perfectly fine to develop a treatment plan in the beginning and have to change it because you find out new information, or you find out that what we initially had agreed on as a treatment goal is a little too hard and we need to back it up a little. So then you create these positive expectations. The program is effective. Research shows that. Parents have, kids have up to 120 days or a year after the close of the program. Kids are still doing well. Parents are still doing well. Families are still doing well. So you essentially portray that to families constantly. And you have small successes in an area so that it gets them to continue doing what they're doing. So they see, hey, you know what? I did that and it worked. Okay, let's continue doing it. So then we essentially look at the area of a dysfunction for the family. We have I presented some general risk factors, but we look at the risk factors for the family, and they might be slightly different than the general risk factors. But then we look at what the problem is and how to define treatment targets. So if a child is using weed, for example, with their friends, we don't target the weed because the friends are also part of that. So this is where we have to take a multidimensional focus. And so what we do is we look at what the parents are doing in response to a child coming home high, how the peers are influencing, what the child is getting out of smoking weed, but what's happening with school, what's happening with community, what's happening with legal involvement. And so then you identify these targets and you address interventions for those. Okay? And we do this through core sessions, and we do this essentially by following the structured process. Okay, so then each MST session has structure. So we always go into a session with a plan. We implement that plan. We look and see what's going on with people, if it's essentially being effective. We adjust as necessary, and we implement a new plan. We look and see if there's feedback, and we continue to adjust. So you're constantly doing a process of assessment, intervention, evaluation, assessment, intervention, evaluation within sessions. So you're constantly looking at what's going on, and you adjust to that. This is useful. So every session involves all three components. So you're constantly in touch with what's going on in the family in the moment. So for example, parents will acknowledge their son's in trouble and they have a big problem. Okay? Parents start to say in a session, we are the medicine. We can do this. We're going to put aside the fact that we're upset at each other and address what's going on with the family. But then the youth get to say their side of the family. And what we're looking for is areas that we can point out that are strengths. So if the adolescent says some kind of underlying emotion that is driving their behavior, we can point that out. And then we set that stage for essentially connecting the parent to the adolescent, and the parent to the treatment, and the adolescent to the treatment. And so then we define goals in their way of saying something. Okay? It doesn't matter if it doesn't look like how we typically formulate treatment goals, because this is about the family and not necessarily us doing things in a particular way. And you're constantly saying what you can help with. So let's go back through the core therapeutic skills. You have to be organized. You have to be able to conceptualize the case and the process. Flexibility is very important. You have to move with what's going on in the room. You can be creativity. You can be creative. You can be think about what's going on and reflect that back. You have to be you have to be able to go in from the second and with a plan and implement that plan. But you're watching to see who's checking out, who's not paying attention, and you adjust to figure out what's going on in that moment. So you're constantly, with families, you're constantly looking at everything that's going on in the situation and addressing that. You don't necessarily stick to your plan. Sometimes you have to abandon it. You're also keeping a therapeutic focus. Everything becomes data for what's going on. And you have to prioritize things. So if you have essentially this idea of how something works and then there is a crisis, you abandon your idea and go with the crisis. And so you're focusing on what's more important. And you're using your time. The idea is to have really good sessions from the perspective of the family, not from the perspective of the therapist. And you're working on really small changes because small changes add up. So if we get parents to think about how they're interacting with their child or with each other, that small changes of just not saying things like the word stupid might result in significant changes. And you use what's happening in the session, that enactment, to promote changes. And so this is where you may move family members around to get them to talk differently to each other. But you consider the flow over time of sessions. So what happened before that's building up and leading to what's happening now, or derailing. So you have to have essentially a long-term and a short-term focus. So then you have to remember essentially what you're doing, what you're intending to do, and you're bringing it out in sessions. Each session can have an outcome, okay? And you shape the outcome, you shape the session to achieve that outcome. And you think about the smaller systems and the larger systems, and you get teens to talk. You know, parents can respond. You know, essentially, what you focus on and how you focus on it facilitates changes. And so then you ask family members to take opportunities in those sessions to make changes and practice it outside. So now we're going to go over implementation so you get an idea of how this is implemented. So the clinical team for MDFT essentially is the whole team is 2 to 3 full-time therapists. They're usually master's level clinicians. So social workers, LPCs, MFTs would be part of an MFT team. There's a therapist assistant who's basically a bachelor's level person, and they're doing some of the case management resources for the therapists. So they might be going out and finding the pro-social resources and helping implement those with the family. But then there's on-site supervision. So you, for students who are graduating with a master's degree and need supervision hours, there's an on-site person who's providing those supervision hours so you can get your independent license. And you want some experience working with substance-using teens, family therapy, and home-based community work. This could be through internships. This could be through volunteer positions. And so they would like you to have some experience, but that's not necessarily required. And so you have to be interested in being a part of an innovative intervention. You know, so if you don't want to, if you want to do your own thing, then MDFT might not be the best thing for you. So then MDFT teams, each therapist has 5 to 8 cases. If you have more severe cases, it'll be on the lower end. If you have less severe cases, it'll be on the higher end. So as you get further into sessions and families become to stabilize, you'll get additional cases, and that's where the change of fluctuation happens. The therapist assistant has about 10 to 12 families, so they're probably working with 2 or 3 therapists at a time. The primary disorder is substance use, even though they're mental health problems. But essentially substance use is what you're targeting, so that's the primary disorder. Treatment lasts 4 to 6 months. This is intensive. So essentially, you're doing 2 to 3 sessions per week with the TA doing other things. And so essentially, you have a small caseload because you're meeting with them more often. You have to be able to do home visits. You working with clients and transporting them somewhere. So if a kid has trouble getting to school, you're taking them to school. If they're having trouble getting to court, you're doing that. You're doing visits in different scenarios. And of course, you get reimbursed for the client travel. But essentially, there are times where during the supervision, you're video or audio taped so that the clinician can give you some guidance on what interventions to do. This isn't penalizing, essentially, or looking at what you're doing wrong. What they're trying to do is help build your skills. And so then you do regular drug tests. So you bring urine drug tests, and there is a process you go through where you administer the drug tests. But then there's some funding for activities such as meals, movies, sporting events. And the idea is that you use this as a mechanism to build relationships and create new connections with situations outside the community. You get mobile phones, and so that you can communicate with families. And so you'll have a separate MDFT phone, and you can use this to communicate with a bunch of different resources. The idea is you're going around and you're in the community a lot, so you're not necessarily office based. So the cell phone allows people to get in touch with you a lot more easily. And then you're going to have email access for consultation. So an MDFT expert and the supervisor work with you to build your skills. So MDFT therapists are optimistic. They're constantly looking for strength. They're working in homes, so you're going to be close to people. And you're going to do what it takes. You're going to do a variety of things to help families. You're not punitive or judgmental. You're not necessarily looking at, well, the parents are terrible and the kid needs to be removed. That's not what we look for in an MDFT therapist. And you're always building your own skills. So you're always looking to become a better therapist. So then there's a couple different things that you're going to look at. You have to be able to look at the systems. You have to look at skill development, dealing with systems outside the family, being able to manage relationships with different people, basically navigating different scenarios, being outcome focused, and you have to want to work in this field. You have to want to work with families and help them improve. And so then what ends up happening is if you look at this kid, some people will look at this kid and think, wow, this kid is essentially being disruptive to the classroom and he's taking attention away from the teacher. But some other people might look at this as like, he's exploring the idea of becoming an astronaut. And so then we are constantly looking at and reframing some things that people are seeing as negative and using this to build an alliance. So in this case, if the kid is looking to be an astronaut, we might connect him with an astronomy group or take him to something where he understands what it takes to be an astronaut. So we're taking what people might see as a negative and turning it into a positive. So the therapist assistant, I'll give you some ideas about how this works. Basically, they're knowledgeable of community resources. And they might not come in knowledgeable, but that's essentially their job. So they become knowledgeable of community resources. They have to be willing to do home-based and community-based work. So it's not an office job. This is you're out working with people one-on-one. And you have to have a passion for working. The therapist assistant has to have a passion for working with families. This isn't something like, well, I'll just do this to see what happens. You have to want to do this. And you have to have a commitment to the outcome and understand that basically what we're trying to do is get kids to prevent kids from being taken out of their home and put into the community. Assertiveness is important, not only with families, but also with the agencies. And so you're constantly calling back and thinking about different ways to get families connected to community agencies and get community agencies to take on these families. You have to have good social, verbal, and written skills. Clear writing is important so that people understand what's going on. And this becomes very important when you're submitting things to the legal system. Because some of these kids might be involved in the legal system, they're going to look at what you write and they're going to interrogate that in the same way that they would someone on the stand. So you have to be clear in your writing and in your verbal skills. You have to be comfortable as a TA working with multiple therapists and managing priority tasks. So organization becomes very necessary. And the idea of you can take all of the things that you have to do and prioritize it. Essentially, this isn't a 9-to-5 job. The schedule is organized according to the needs of the family. So during school, you might have nights and weekends that you're working on. Essentially, what we're trying to do is not necessarily work from 9 to 5 with these families, but work in a way that connects them, keeps them connected to community agencies. And so then you have to understand collaboration and cooperation. So now in terms of supervision, this is simple, and this goes to people who are going for their license. Basically, you have weekly individual supervision. So you're meeting with your direct supervisor, and you're talking about case conceptualization. You're doing session planning sheets. So they're getting you to understand, essentially, to plan out each session so that you go in and you have this understanding of what needs to be done and how to think about the cases. That's the case conceptualization. You have live supervision. This is with an MDFT expert. They'll review videotapes. Okay, so you in sessions, clients end up getting comfortable with videotaping. They forget it happens, and so do clinicians. But you introduce this idea that they're looking at how you're helping the family and what guidance they can give you. But then you have weekly team supervision and a phone consult with a trainer. So essentially what ends up happening is that as you're going through MDFT, you're constantly building your skills, which is where you have to be willing to go back and understand that what you're doing is about constant skill building, and people are going to help you with that. And it says 24-hour, 7-day availability, but there is essentially you're available for crises, and it gets transferred for clinicians. So there'll be a point in time where you're on crisis calls. Typically, what I've heard from providers is that they don't get a lot of crisis calls, but just knowing that it's available helps families try and figure it out. And they're essentially implementing the skills that you've done in session, outside of session. So then the idea is that there's a parallel process to between treatment and supervision. So what you're doing with the family, which is constant skill building, multi-systemic approach, the supervisors are doing with you. So they're helping you think about the multiple systems that are interacting, but also building your skills. And so they're looking at, essentially, they're modeling direct communication. This is how you directly communicate. They're helping you think about different ways to problem solve. And they're instilling help in you when you feel like everything is getting stuck. And they're ongoing supports. So there's a lot of a buoying of your clinical skills as they're going through this process. So then what the supervisors do is help you see the big picture and the little picture. So the forest and the trees. So that you get, you're constantly developing that skill and looking at that. And they're reminding you of the principles of MDFT. So they're making sure that you're doing MDFT that's following this principle, that you're being strength-based, you're problem-solving, you're looking at adolescent development and a multi-systemic focus. But they help you identify what's going on with the family. So you're not necessarily doing this on your own, but they're essentially helping you think about the family and what part of culture, broadly defined, is going on with the family. So they're constantly helping you think through what's going on in your practice, and it ends up building your skills and your knowledge. And essentially, you're working as part of a team. Remember, there's 2 to 3 therapists there. So you're not doing this alone. It's very different than other forms of intervention where you're essentially the only one thinking about this. You're constantly a part of a group that's going to help you build your skills and help these families. And they're making sure that you're treating the family, treating not necessarily how you're interacting with them, but what you're doing is of high quality. Now, in order to do this, essentially there's trainings. And the training is essentially getting you to understand that all the elements of MDFT have been tested and are shown to be effective. And essentially, they're looking at essentially getting you to operate within an MDFT structure. And so there's all these different processes with MDFT that is essentially ensures that it's effective. And there's ongoing training, so it's not something where you're one and done after the beginning, but you go through an initial training and then you're constantly monitored and getting ongoing training so that you're successful in your treatment. And so then essentially there's a 5-day training that goes over the basics of MDFT and some of the different processes. And then you go through and you start building your cases and you start submitting your forms, and you're constantly being given supervision as you're going through this. So they're making sure that you're as effective as possible. And so then you have monthly calls with MDFT trainers, and they're going through your cases and helping you think differently about this. And your supervisor's there. So it's essentially every single person is getting trained as you go along. So this is a very intensive process. The trainers visit the site, the agency that you're working with, for a more intensive case review and live supervision. So you have someone who has been doing this for a very long time, helping you and your supervisor understand what's going on with the family and coaching you in this. And then you do an essay exam, which is essentially you talk about MDFT and what you're working with the family, and you submit a videotape where they help you understand if you're maintaining fidelity to the model. And this is the problem-solving, strength-based, motivation-focused part of the training. And then you become certified. And then you're recertified by the MDFT every year. So that essentially this certification says that you are trained and effective in implementing MDFT. So then essentially you're going to be doing case consultation with the trainers. You're going to present cases for discussion, and they're going to help you think through this. And this is during your supervision, this group case consultation. So there's a lot of supervision to make sure that you're effective and that you're building your skills in all the domains related to MDFT. So at times they may educate you on adolescent development, maybe because there's something that you're missing or don't remember. So then you have to complete all the case conceptualization forms. So all the tracking information has to be completed. You have to participate in the training. And you observe these sessions. You see what's going on. So as they're talking about somebody else, you're seeing what's happening and what they're saying about how to think about this case and how to intervene. And you're learning, And they give you these real clear, very focused analysis of the therapy that you're implementing. So then you're given time to study MDFT. The manuals, books, adherence. So essentially, as you're going through this, you're constantly building your skills. You're watching videos of good MDFT work. You're watching videos of your own sessions so that you can improve. You're collaborating in training, so you're constantly developing your skills. At the end of this, what ends up happening is you become a skilled family therapist, and you're able to look at the multiple dimensions. And people have used some of the training that they've developed in MDFT to do this with people when they're outside of MDFT. So some of the knowledge that comes with MDFT does apply to families who are dealing with disruptions because families rejecting a person because of their affiliation with the GLBTQ community, with essentially drug use. But essentially, what you're doing is taking all of the skills that you have and applying it to families. I hope you look forward to learning more about MDFT in the readings, and I will see you later.